Okay, sir, we are live. We can begin.
So, hello, everybody. My name is David Hargroves, and I'm a consultant stroke physician from the UK, working in England, in South East Coast, which is a region in Kent. And my training has been in stroke medicine, graduating from University College London, and undertaking postgraduate training at King's College London. And my research thesis was in using near-infrared spectroscopy, looking at cerebral oxygenation in the acute phase post-stroke. So I'm a practicing stroke physician, and I manage and lead a stroke unit which looks after 1,200 patients that suffer a confirmed stroke per year, and we have another 1,600 to 1,700 patients with a mimic. We also look after 2,500 patients with a transient ischemic attack per year. It's a pleasure to talk to you from the UK Stroke Forum, which is the largest multidisciplinary international meeting for stroke, occurring at the moment in Telford in England. My disclosures are hopefully on your screen. And what's important to say is that I have been involved with various clinical studies as local PI, looking at the use of the novel or anticoagulant agents in the management of cryptogenic stroke, most recently Navigate ESUS. So over the next 50 minutes, what I'd like to talk with you, and then we can have some questions, is regarding the heterogeneous nature of neurovascular disease, the various causes, particularly focusing on atrial fibrillation. But the underlying process, of course, is occlusion of arterial flow, and really highlighting the absolute requirement that we appropriately prevent the most important preventable risk factor in cerebral ischemic vascular disease, which is atrial fibrillation. Most patients will require anticoagulation, but it's not always straightforward. And it's important to choose the right agent at the right dose for the right patient. So as I alluded to, the pathophysiology for arterial occlusion, moving from ischemia, where symptoms develop, through to infarction, is demonstrated on this diagram. But what's important is it's not a linear process. And we know that we have patients that can have an occlusion of a large vessel, develop symptoms, but in fact we find that the ischemic penumbra is potentially salvageable many hours and sometimes even days after symptom onset. And I think it's important that we move to a tissue-based diagnosis of ischemia and infarction as opposed to purely time. And one I think of the key points that we're moving to now as the result of the recent MR studies, Diffuse and Dawn, is that it is a tissue-based diagnosis as opposed to a time-based diagnosis. We talk about this ischemic penumbra and how each individual patient, dependent on the flow deterioration, will develop symptoms, but some of them, those patients, are amenable to recanalization therapy. But once you get down to less than 20% of the normal flow, about 10 mils per 100 grams per minute, you find that those tissues are irreversibly damaged. And those patients do not benefit from any recanalization therapy. And in fact, they're the patients that potentially go on to suffer intracerebral hemorrhage at the focus of their initial ischemia. So you're all aware of the various pathological processes that can cause ischemia. We traditionally learnt and were taught at medical school that these were predominantly in four main types: the small vessel, leukocariosis disease, the large atherosclerotic disease, and then those that are coming from the heart itself, the cardioembolic phenomena, usually from the left atrial appendage, or occasionally from the arch aorta. And then the fourth group, of course, is the cryptogenic and rarer causes. Initially, we always used to think that cardioembolic stroke was probably only 25%. Of course, we know now from registry data that it's probably a lot higher than that. Maybe even 30 or 40% of all ischemic strokes are caused by cardioembolic phenomena, and most often atrial fibrillation. So we know that it's a huge international burden with regards to disability, and of course, particularly in the Western world, it's the largest cause of adult disability. Over 15 million patients per year suffer a stroke, and of those, at least a third will be dead and another third permanently disabled. Those four groups that I alluded to before regarding the large vessel, the leukocariosis, and the cardioembolic phenomena, and then we have this group of cryptogenic, of likely cardioembolic etiology, which is now the fifth group that we commonly think about. So on your screen, you can see that there are 12 potentially modifiable risk factors which we can do something about regarding lifestyle choices. And my particular research interest is obstructive sleep apnea, and certainly this is a common condition affecting potentially 1 in 7 adults over the age of 30, but it's poorly diagnosed and poorly appreciated. I think it's important with all our patients with coronary and cerebral vascular disease that we do take a sleep history so that we ensure we don't miss this group of patients. And a standard sleep history using a modified Epworth score, but also looking for evidence of nocturnal sympathetic overactivity. And by that I mean the nocturnal sweating, the nocturia, the dry mouth, drinking water at night, as well as snoring and partner reporting apneic events. And certainly in our Royal College of Physicians guidelines for the investigation of patients with ischemic stroke, we talk quite clearly about the need to undertake a sleep history and to investigate anybody who has an elevated Epworth score of daytime somnolence and or evidence of nocturnal sympathetic overactivity. And so interpreting that in my practice, if a patient has daytime somnolence or they sweat, they have nocturia at night, we perform a formal sleep study. And again, in our local practice, we find 20 to 25% of all patients that come through the cerebrovascular service have an abnormality of sleep. And of course, what we do know is that management, even though it's challenging, of those patients does reduce the recurrence rate of ischemic stroke, but also the potential for them to rehabilitate. It'd be great to talk about all the other 11 causes, but in fact, we're going to focus on atrial fibrillation for today's webinar. So pathophysiology is the left atrial appendage, which stores and has a propensity to have thrombus formation, particularly with a failure of regular sinus control within the atria. I alluded to the fact that we were all originally taught that maybe only 25% of all ischemic stroke patients have the cause as atrial fibrillation, but certainly in the UK, when we analyse registry data, we find it's a lot higher than that. This is publicly available data from a few years ago, and it demonstrates the number of patients that at the time of discharge from one of the 122 acutely admitting stroke services in England had co-coded diagnosis of atrial fibrillation. So that's not to say that atrial fibrillation was the cause in all of these patients' strokes, but it was co-coded at the time that the patient was discharged. So you can see almost 40%, a slight decrease. We also know from general practice registry, so primary care physicians, and then this is English data, that most average GPs will have between 20 and 25 cases on their list of patients with known atrial fibrillation, and they're likely to see 3 new cases per year. Approximately 1 million people in England currently have a diagnosis of atrial fibrillation, and we think there's almost 500,000 that are undiagnosed. And what we do know, of course, is that most of those, as a result of paroxysmal atrial fibrillation, where half of those patients will be completely asymptomatic. We know that over time, the incidence as our population ages is going to increase. And as a result, the global burden of cardioembolic associated stroke is only going to increase. And this is projected data over the next 20 years. So if you have atrial fibrillation, a patient has atrial fibrillation, whether or not it is directly the pathological process that causes the ischemic stroke, there is an association with an increased likelihood for all cases of atrial fibrillation of having an ischemic stroke, up to a 5-fold increase. Regardless of which study we read, we find parity regarding the number of, or the incidence of stroke, irrespective of whether it's sustained or paroxysmal atrial fibrillation. Of course, the jury's out with regards to how much paroxysmal atrial fibrillation one needs. But of course, the reality is that over time, your paroxysmal atrial fibrillation, as your left atrium dilates, increases, the duration increases, and we have various cutoffs across the world. Some use 6 minutes, others 3, but most stroke physicians, without an alternative pathophysiology, would suggest that up to 30 seconds of PAF is enough for us to consider anticoagulation. Of course, the outcome for patients that have suffered an AF-associated stroke is significantly higher than other forms of ischemic stroke, with up to half of all patients with AF-associated stroke being dead at 1 year. This translates to a 70% increase in hospital mortality, a 5th more likely increase in length of stay, and a 40% relative decrease in the chances of those patients leaving hospital back to their normal place of residence. And of course, this is a surrogate marker for functional outcome. How do we risk assess people with atrial fibrillation? How do we determine what their risk per annum is of suffering a stroke or systemic embolus? Well, we should all be using risk stratifying calculators, and the CHADS-VAS score is a universally recommended indicator. This has been updated from CHADS-2, and of course it's a 9-point score, and with each point you increase your risk per annum of having a stroke or systemic embolus. Of course, the incidence of stroke is approximately 1.7 per 1,000, dependent on other factors. And you can see that patients with atrial fibrillation at the highest group, the CHADS-VAS of 9, have a 1 in 4 chance of having an event, compared with roughly 1 in 500. So lots of US, UK and European guidance. This is ESC guidance, suggesting that when we risk assess someone with atrial fibrillation, we should be doing the CHADS-VAS score. And of course, it's important to determine what we mean by non-valvular atrial fibrillation. And in essence, this is all atrial fibrillation other than symptomatic severe mitral stenosis, usually secondary to rheumatic heart disease, or those with metallic bowels. So certainly in Europe, this makes up about 95% of our AF population. Once patients have been risk stratified using the CHADS-VAS score, it's important to note that anyone with a CHADS-VAS score of 1 or more should be actively considered for oral anticoagulation, and certainly the case for patients with a CHADS-VAS score of 2 or more. The other important point to note is if patients have not had a previous stroke or other risk factors as part of the CHA2DS2-VAS score, and they're under 65, they shouldn't have any treatment whatsoever. So aspirin has no role in the reduction of cardioembolic stroke in atrial fibrillation. When I say no role, relatively little role, and we should not be considering antiplatelets as an effective intervention with patients with atrial fibrillation. So what is the data regarding which agents to use? So the slide you see currently is the pooled analysis, and the reference for this is the Lancet 4 years ago. And this is the pooled data from all the 4 NOAC studies versus warfarin. And what we can say with confidence to our patients is that taking a NOAC is certainly safer than warfarin with regards to intracerebral hemorrhage. And depending on which agent we choose, as good as warfarin in preventing systemic embolus or ischemic stroke. So we have these new drugs that are at least, and in some cases better than warfarin at preventing the stroke, but they're certainly safer. Now, no one's going to be able to tell you, unfortunately, which of the 4 NOACs is better than the other, because there hasn't been, and there never is going to be likely, a head-to-head randomized trial between the NOACs.